Good morning. I'm going to start us out today, and I just want to thank the OLTCA for providing this opportunity for me to travel to Toronto. This is my first visit to this beautiful city. I think next time I would like to come in the summer. Even though I'm from Minnesota, you would think I would be adjusted to this, but it's been a little brutal. So we'll go ahead and get started. I better make sure I know how to run this. Great. So I'll just start out with giving a little bit of background about Minnesota and our nursing facilities. We have about 375 currently in the state. We've been going through over the last 10, 15 years a major downsizing in the number of nursing home beds in our state. So we're at about approximately 31,000 beds right now. We run about a 90% occupancy, and it's declining. And so nursing homes in Minnesota are definitely competing for market share. And I think that that's also contributing to some of the success of our PIPP program that we're going to talk about. We are a RUG state, so we use the RUG classification scheme with 48 groups for our payment system. And we have transitioned to the new MDS 3.0 as part of that. What's kind of interesting about Minnesota that's unique in the states is that we do not pay average facility rates. We have each facility in Minnesota has their own set of 48 group rates, and then we also pay individually on a resident-specific level. And so it's kind of a complex payment system, but it's very, very specific to each individual in our nursing homes. And the other piece that's kind of unique is that Minnesota is one of two states, North Dakota being the other one that is a rate equalization state. So what that means is the private paying individuals pay the Medicaid rate, the rate that we establish at the department. And so the only exception to that is that a facility may charge a private paying person a higher rate for a private room. But otherwise, if they're in standard occupancy, they are paying the Medicaid rate, which becomes an important piece as I talk about how we fund this performance incentive payment program. Dr. Grabowski was very complimentary about Minnesota's quality system. I just want to acknowledge that, but I also want to talk about it. It didn't happen overnight. We started working on our quality system. And I was participating in that back in 1998. So our systems evolved over about 16 years to where we are today, and we certainly never stop. As you know, the nursing facility industry itself is constantly evolving, which makes it important for us to be evolving with that and stay modern, I guess, as you would say. So we work very hard to do that. We have a multi approach to quality, and so just briefly I wanted to talk about where we started was with the Minnesota Nursing Home Report Card. And I'm sure some of you are at least familiar with the federal report card system that the states has called Nursing Home Compare. So the question is, why is Minnesota doing their own report card? And there's a number of reasons for doing that. And this was very important to our providers and our stakeholders, is that the report card be a very fair and equitable system. And so the risk adjustment piece of it became very, very important. And so the Minnesota measures are more extensively risk adjusted than the national quality measures. We use the same basis, the MDS 3.0, for our quality measures, but we do a more extensive risk adjustment to make them to level the playing field if we're going to use it both in a public reporting system as our report card is, and also as a basis for pay for performance. The other important feature about the Minnesota report card that's lacking in our national report card is the consumer perspective. And we place a lot of emphasis, and I'll be talking a little bit more about how we measure the consumer perspective. And interestingly enough, I just want to share a little recent research that was done. Ohio also has a similar system for a consumer survey process. And so there's some research that was done making some comparisons. And so folks that use the national report card to make a decision or to rank their choices based on the quality that they're perceiving off of that report card, there's very, very low correlation with the consumer perspective. And so you could be making that choice, but without that very important consumer perspective, that consumer would more than likely not be experiencing the same perception of quality that was indicated. So we really, which supports our opinion all along that that's a very important feature of a quality system. So just briefly, what are the domains that we look at in our quality measure system? We have the more obvious input process pieces, of course. We do look at direct care staffing per resident day. It's case mix adjusted. It's also cost adjusted. So an RN, for instance, is valued 2 times higher in their hours versus the nursing assistants. And we also look at staff retention rates. We collect data on that and report that. I've talked a little bit already about our nursing home quality indicators, the clinical ones. We have both short stay and long stay risk adjusted measures. We do have a component that looks at the regulatory process and how we create a deficiency score based on the results of the regulatory surveys. We are about to release a new hospitalization rate, looking at both 30-day hospitalization rates and long stay. Again, those are risk adjusted, probably slightly different than some of the federal publication of the hospitalization rates. And then again, the resident and consumer perspective. Right now, we do a resident quality of life survey. We do about 13,000 face-to-face interviews with residents, a sample in each facility. We do contract with an independent research firm to do those interviews for us. Here's an example where we need to evolve with the times. Our nursing homes are doing more and more of the short stay business, cycling those beds very fast. And so we're planning now to separate the consumer survey for short stay and your more traditional long stay residents. We'll continue with the face-to-face interviews with long stay because we want to make sure that we capture the perspective of folks with dementia where we can successfully do that with a face-to-face interview, but we will probably transition to a mailed survey for the short stay folks so that we can capture their perspective, because obviously their expectations about their time in the nursing home is very different, and so I think we need to be adjusting our data collection to reflect that. We also do an annual family satisfaction survey. That's a mail survey, and that's relatively one of our newer measures as well, and so we haven't added that to the report card yet, but we do intend to do that very soon. And we are also in the development stage of community discharge rates, looking to see how effective nursing homes are at preparing residents for a successful discharge and a stay in the community. This is just a quick brief shot of what our Minnesota Nursing Home Report Card looks like. I wanted to put it on a slide, so if you're interested, here's the web address, and you can go in and take a look at this. The one feature that we really like about this report card is that most report cards, whoever designs the report card, it develops a composite score. And so that forces the designers to weight each measure and to develop that composite score. What Minnesota's report card is, how that's different is that the user weights the measures. And so they go in and pick what's most important to them. Is it the quality of life, or is it the clinical quality? And they make those selections first, and then as you select your geographic area that you are interested in looking, the facilities will be ranked by and weighted by according to your preferences. So it's kind of a cool little add-on to that. So now to get into our pay-for-performance strategies. Again, we use a multi-prong approach here. I think we were talking about in Ontario, it's probably a lot like the States. At the federal level, there's funding contributed to long-term care, but really all of the innovation and the reform, payment reform, quality approaches are taking place at the state level. And so in the States, there are a huge variety of pay-for-performance models that are in place for nursing facilities. And we in Minnesota kind of have a little bit of all of those. We do have your more standard quality add-on that it's like a bonus system. So on an annual basis, you'll look at how facilities performed on these quality measures, and they'll earn a bonus payment. The quality add-on for us is subject to appropriations, and so we don't always have one every year. It depends on the budget situation, and so that one is a little more iffy because once those bonuses are put into the facility's rates, they stay in there and they become part of their base, and so it gets rather expensive to keep funding those. So it's always a kind of a battle to get the funding to continue the quality add-ons. A new program that we're just starting now is quality improvement incentive payment. And so rather than just always the high performers getting all the bonus payments, this is an opportunity for people to earn an incentive payment regardless of where they're starting. So even the lower performing facilities have an opportunity to earn a payment. And so what they do is they declare one of our clinical quality measures or one of our quality of life domains that this is the our focus area to try and earn this incentive payment. They declare that to us up front. They have about a year to work on that. Then we look at their performance following that to see if they, we have this sort of pre-established target that they should receive. They get to that target, they get the full incentive payment. This program is designed to be a revolving amount of money. So they get that payment for 1 year. Then we take that pot of money and redistribute it the next year. And so this program is ongoing, and we just keep redistributing the same money annually in their daily payment rates. And then we have our third program, which has got the biggest chunk of funding involved in it that I'm going to talk a lot more about today, and that's our PIPP program. The really unique piece about this is that PIPP provides the resources to the facility up front to start on a quality improvement project. It's not a grant, it's not a lump sum payment, but what we do is at the start of their project, we raise their daily per diem rate by with this incentive payment. And so they have those resources throughout the life of their project to dedicate to these quality improvement activities. And then the performance period where we look at how they did typically will extend beyond the period where they were getting the incentive payment. And I'll talk a little bit more about how that works. So let's get into the specifics of the program. I think people that have evaluated this program, and one of the things that makes it so unique is it's really a partnership between the state and the providers. It's a grassroots approach. It's not the state saying this is what you are going to work on. This is your area of emphasis for this year. And so what we do is the idea is for providers to look at their own organizations and determine, where do they need to do some improvement. And so the idea is for us to partner with them and provide the resources to help them. The other thing about PIPP that I think makes it so successful is its flexibility. Again, it doesn't take legislative action and all sorts of declarations about where are we going to focus now. It's just whatever starts to emerge, and the good examples are the emphasis on reducing antipsychotic drugs, for instance, the emphasis on rehospitalizations, the emphasis on transitions to community and community living. And so these are the things that our providers are responding to through the PIPP program to respond to these emerging issues as they come along. So the goals of the PIPP program were designed obviously to improve care, provide higher quality care the most efficiently as possible. The other pieces about this is to really encourage experimentation and innovation. Many of our, Minnesota is very heavily nonprofit. These facilities are governed by volunteer boards. And so with the PIPP funding, leadership in these facilities can convince the boards, you know what, let us try this. We think this is going to work. Without that kind of funding, those kinds of decisions would never get off the ground. And the other piece about that is this dedicated funding to these quality improvement projects. So the leadership, all the way up to the boards, it's like, okay, we're getting money, we're getting paid to do this, and so let's really focus on this. And so the staff and the project leaders and champions are not being forced to be distracted with other things. They are given the ability to really focus on these projects. And the third goal is to equip facilities with organizational tools and expertise. And I just want to talk a little bit about the framework of PIPP here, because I think this is really key to the success that we're seeing, and what some of the results that Dr. Arling is going to share with you is that the framework of PIPP, they have to submit an application, and it's very, prescriptive about what's required. And so what we do is we force facilities to think about your basic quality improvement framework, which is, what's the data? What is your measurement? What quality measures? What's it telling you? What is the story your data is telling you? What have you learned about the root cause analysis? And then it's like, go through this root cause analysis project, develop a strategy that addresses what you've learned in your root cause analysis process, and then tell us about how you're going to monitor your progress. What are you putting in place to see if your strategies are working? And then tell us about how you're going to sustain that improvement. So all those components are required to be a part of that initial application. And the biggest thing, and we're into our 8th year, and it still happens, is that people have a tendency to think, they hear about something cool that's happening in some other nursing home, some other states, actually other countries. I've seen, proposals, something that they've, come to Canada and picked up on. And then they go looking for the problem that they want to solve. And well, that doesn't work. And so, we do an annual PIPP boot camp to help providers, particularly new people into the program, to walk through this process. And my favorite example of that, where they heard about something cool and they want to do it as an organization, send some representative to the boot camp, and they introduce themselves as being from the philanthropy department. I'm like, oh, this is going to be an interesting day. What do you really know about the systems in your buildings that are contributing to wound issues? And it's like, we're going to spend all day today sharing with each other, talking about root causes of the various projects. And so so that, I think, is a classic example of, let's pick something cool and then let's see if we can get PIPP money and find a problem to solve. So, and again, it's an incentive program to, encourage facilities to invest in quality improvement. And then the other key piece of this is and the state takes this role on, but our providers are doing an awesome job of doing that too, is sharing what's working. They're sharing with their peers. We do a lot of dissemination activities through newsletters, conferences, and mentoring arrangements, and I can talk a little bit about that in a minute. Just to step back, like I mentioned, we're in our 8th year of this program. The funding is about $6.7 million state share, but we do get the 50% federal participation on that, so that doubles that amount. And then because we're rate equalization state, we're raising those daily rates that the private paying individuals are paying as well. So it's about $18 million a year that we infuse into the industry to work on these quality improvement projects. So it's quite significant. It is a competitive application process. It's not as competitive as you might think. We typically fund 80 to 90% of the applications that we get every year. And so we keep trying to encourage more and more facilities to come in, and there's this perceived barrier that it's very difficult to put a project together. And so, we're trying to address that and grow the program. So the idea is, again, just kind of go back to that framework that I talked about, start with the data. They identify a problem. They develop, hopefully an evidence-based type intervention, but again, we encourage innovation. So we have groups of facilities, particular, that are creating an entirely whole new strategy. They are eligible to receive up to 5% of their daily operating per diem. So as I mentioned, it's an add-on to each of the RUG group rates. It's a fixed rate that we negotiate with between the state and the provider. That amount of payment that we negotiate depends on the scope and complexity of the project. The incentive payment can go anywhere from 1 to 3 years. We look at how important is the issue, what proportion of the population in your facility or facilities is this going to impact. There's lots of things that kind of go into what's your budget look like into this whole negotiation of what the incentive payment will be. The other key feature to this is that for everybody, the 20% of the incentive payment is at risk of achieving performance targets. And so part of the negotiation, again, with us and between the providers is picking performance measures and picking the improvement targets. And if the facilities or the collaborative working together on that does not achieve those targets at the end of the performance period, the state can potentially take some of that funding back. And again, we don't take it as a lump payment back. It becomes a prospective rate decrease. But I can say in all 8 years, I mean, this system is really quite effective as far as there's a lot of pride. They don't want to be one of the handful of this entire program that's lost money in the incentive program. And the state has also had to be a little flexible in this because we all were learning, particularly in the early years, what is a reasonable amount of what's a reasonable expectation for improvement. The measures changed when we went from MDS 2.0 to MDS 3.0. That really kind of upset our, trends, and so we've had to have some flexibility in that area. But that 20% is, again, goes back to the leadership thinking we do not want to do that. We do not want to lose this. And so that's, again, it enforces emphasize the staff attention and leadership support for these various improvement projects. And then again, as part of the application process, we really look for a sustainability plan. And so the types of projects that get funded are those that typically the best ones are, some of the resources are being invested up front in education. It's developing new processes. And so at the end of the project, it doesn't require resources to keep it going. It's the way we do things now. It's fundamentally changed the system within the organization that's led to this quality improvement that's just self-sustaining after that. And that's primarily been the most successful model and the kinds of things that we're most likely to fund in the competitive process. Here's just, and this should be updated. We're missing a year's worth of projects here, but this is the number of facilities and number of projects and the types of projects that people are working on. I did look at the 5-year strategic plan for OLTCA. Paula shared that with me, and as I was reading through, the executive summary where you're looking at cost, quality, access, innovation, and I could clearly you're dealing with the same kind of issues we are dealing with, because you'll see that all of these types of projects fit into that framework very well. And so I found that really kind of interesting that we're all in this together. We're all dealing with the same issues. As the program first started, clinical quality was the priority in many of the projects. We've evolved into, I'm going to move on to this next slide, because this has really been kind of interesting. The very first round, we didn't know we were doing at the state. Providers didn't really understand this whole framework. We all had to learn together. We all knew it was supposed to be innovation we were after, and of course, when people think of innovation, the first thing you think about is technology. So technology was heavily focused in the very first round of this. But we quickly realized that's really not what we wanted this program to do. We were after that innovation in the organizational system and care processes. And so we really started to move away from the technology being the focus. Many of our projects use technology as part of one of their strategies, but we moved away from that being the primary focus. I always like to use the example, just because you buy a technology is not going to help. It's like you go buy, Big Bertha's not going to help your golf game. You got to do something else besides that. And so what we de-emphasize the purchase of the technology and focus more on, what are you changing about your organization and your processes that's going to make this work? And so again, this kind of demonstrates how we've evolved into, you'll see in round 5, that's about the time when the ACA came out with all the emphasis on rehospitalizations. And so you see there's a large emphasis or number of projects that went into dealing with transitions. And now we're kind of into round 6, because one of the trends we noticed in our data is as Greg will be sharing the quality indicator trends, which are very positive, but our quality of life is pretty flatline. We are not seeing the kind of improvement in quality of life that we'd like to see. And so we started emphasizing PIPP as an opportunity to start working on that, and the industry has really responded to that. And that's why you're starting to see much more of this organizational change. Quality of life is a much tougher nut to crack. And I am so appreciative of all of these providers willing to take it on. And so we're really seeing some, really remarkable results. There's a lot of this person-centered attention, or, person-centered care going on, whether it's dealing with mood, depressions, activities, sleep, a good night's sleep. There's lots of things that are going on that's trying to get at this improving quality of life. Just briefly, again, back to the measures. Any good pay-for-performance system has to have a valid measurement system. Minnesota is really struggling right now, given the success we've seen in nursing homes. We want to expand pay-for-performance into our home and community-based services system. We've been talking about it for years. We can't seem to solve the measurement problem. And so we're still continuing to work on that. But our primary measures we use in the PIPP program is the Minnesota Risk-Adjusted Quality Indicators and these resident quality of life ratings. And I should mention that quality of life scores are also risk-adjusted. That's important to us. We know that our urban versus rural, for instance, rural residents are more likely to report a higher quality of life. And we adjust on facility characteristics, and we also adjust on resident characteristics. But other measures are starting. Again, the family satisfaction survey is relatively new, but folks are starting to use that in their projects to again get at some of that person-centered care. And what are the family observations about relationships, individuality, autonomy? Those are all things that we address in our quality of life survey, but we also pick up on some of that in family satisfaction. The other response, we're starting to see a lot of projects right now that we haven't seen before on direct care staff retention. As the economy recovers, clearly they're having trouble with staff retention. And so we're getting a lot of projects that are trying to improve employee engagement and create environments where staff want to stay. And then again, the rehospitalization rates. So what are the challenges for administering this program? It's resource intense from the state's perspective, for sure. It requires a lot of skilled staff at the state that know how to do this, provide technical assistance. We, as I've already talked about, we have to constantly keep up trying to update our quality measures, and so we constantly have the development and the research going. Unfortunately, we've had this very long-term relationship with the University of Minnesota and with Indiana University, so that's worked out well for us. And the other thing is I talked about is getting the entire industry to participate. We want everybody to come into this. We have about a third of the industry that hasn't participated at this point. I mentioned the PIPP boot camps that we do every year. We have a full-time quality improvement coordinator who is a long-term care RN that's worked many years in the industry, who provides technical assistance. And we have mentoring arrangements where we will pay an incentive payment to a nursing facility or a group of nursing facilities that has been successful in PIPP, so they can earn a payment to mentor a facility new to the program. So we've got a lot of arrangements going on to bring people in, but that's been one of our biggest challenges. And the other part is, it's kind of an oxymoron. You negotiate with the state. I mean, you're probably a lot like we are. Every little detail is written into legislation. It's like you don't have a lot of flexibility. And so when we first started this program, I thought, oh my gosh, we're going to negotiate? How is this going to work? But surprisingly, it has worked. But we do have to be very fair, transparent, and flexible with it. And I think that we very quickly, in the early years, were able to develop the trust with our providers. At first, people are like, yeah, there's a catch to this. I know there's a catch, and we're waiting for the shoe to drop on it. But we've gotten past that, and the whole negotiation process seems to work pretty well. And again, it's tricky, and we've had to learn, and we've learned a lot in 8 years, but we're still learning is what's the right incentive payment, what's the right measure, and what are the right improvement targets. Benefits to the state. We're interested, of course, in a return on investment, but as Dr. Grabowski talked yesterday, many of the projects and the success that we see, the Medicare's benefiting, not Medicaid necessarily. And so it's been tough to create a business case for Medicaid. But we're still looking at that. I mean, we know that there are some, for instance, these successful transitions to the community. I mean, that's clearly got a Medicaid benefit. And so, there's areas there, but the hospitalizations, reductions in medications, reductions in falls, all of those are clearly a benefit to the Medicare program. But on the other hand, we see a very, what we would call soft benefits or soft returns to the state. Obviously, we're getting improved quality. That's huge. How much are we willing to pay for improved quality? I mean, this is the story we have to keep convincing our legislative bodies to keep funding. It's like, we're getting improved quality for this enhanced funding. So, we're learning from some of our most innovative providers. We have some amazing providers, and so we're learning when we're able to disseminate that to the industry as a whole statewide. It's led to some very strong enhanced relationships with our providers. The other key piece, and I think this is again a point that Dr. Grabowski was making, is that it's leading to our partnering with other quality improvement organizations in the state. For instance, the Medicare-funded Quality Improvement Organization. We have started working together. We work collaboratively to lead some projects, some PIPP projects, so that they provide some technical resources to do that. And so those kinds of arrangements are starting to evolve, and I think that we're going to start to see, eventually lead to a more of a partnership with Medicare in some of these programs. Greg will be sharing the impact on nursing home quality, and what I'm most excited about is what he'll share with you is about what's happening with the skill development in our nursing homes and the organizational change that's been occurring. So with that, I will turn it over to the research.
Well, the researcher has to figure out how to move this. I guess it's 2 buttons, so I can figure that one out.
The green go arrow.
Yeah. So whenever my wife leaves town, I have to get detailed instructions on how to work the TV and the DVR because I went a whole day without being able to watch TV because I couldn't figure out how to turn it on. But anyway, I'll figure this one out. This is a hard acts to follow. First, Dr. Grabowski, and then Val talking about the PIPP program. What I'll do is share with you some results we've had from our evaluation of the program. And we were lucky enough to get a grant from the Agency for Healthcare Research and Quality, our federal sort of health services research funding agency, to do a study of the program. And I'd have to say what really sold this evaluation, and this is an extremely competitive period now for grants, what really sold this evaluation at ARC was the project itself, which they felt was innovative and something that they wanted, the program itself, the PIPP program, something they wanted us to study. I'm at Indiana University in the School of Medicine. I'm a PhD, but I'm in the Division of Geriatrics and General Internal Medicine. I was at Minnesota for 5 years and developed a relationship there, and I have colleagues there as well as the relationship with the Department of Human Services. And so this sort of natural relationship, or we build on this relationship in carrying out the evaluation. Dr. Grabowski yesterday talked about some of the failures of pay-for-performance models in various environments, and this isn't just a nursing home setting. It's with physicians, with hospitals, and whatever. The challenges are basically trying to address these issues. First of all, how are you going to get broad range participation? And how are you going to make sure that people at the low end are engaged as well as the people at the high end? You want to avoid attracting the best, just the best and the brightest. Secondly, you want to change quality, okay? And many of the programs have not shown or demonstrated quality changes. Thirdly, there's the whole question of when you devote resources to a particular area, focus on a particular area, what happens to the other areas of quality? And one argument is that it's an unintended consequence that when quality goes up in your targeted area, it goes down in other areas because it's not getting the attention of the resources. So that's a challenge. And then what impact overall has the project had on the organization? Has it brought about fundamental changes? And then is it return value to the facilities? Is it a good investment from their perspective, from the provider's perspective? And then finally, was the project sustained? Okay? So to have a really effective program, you really need to attract a broad range. You need to improve quality. You need to bring about organizational change. You have to return value, and you want it sustained over a period of time. So we're going to look at each one of those issues and look at the evidence from the evaluation. First of all, the PIPP program has had broad-based participation. As Val had said, it's been increasing each year. And if we look at the characteristics of people who've gone into the program and those who have not participated, and we look at baseline before the program started, we find some differences. The PIPP facilities tend to be larger, more nonprofit, heavier case mix, and located in urban areas. I might point out that there's a lot of overlap here. It's not, they don't sort out as being all urban or all heavy case mix or whatever. There's considerable overlap, but there is a tendency in this direction. But importantly, if we look at the resources of the facilities that have participated in the program, they don't have any different nurse staffing levels. Their operating costs are not significantly different from those who didn't participate, and the reimbursement rates at baseline were no different. So in that sense, they were not advantaged from a resource perspective. Importantly as well, there was no significant difference between the PIPP-funded facilities and those who didn't participate in their clinical care quality measures or their other quality of care. So they started at least at the starting line at this relatively the same position as the other facilities. When we look at the improvements in quality, what we're doing here is we're comparing the PIPP-funded facilities to those that were not funded by the program and seeing whether there were differences between the two, and use a statistical model here based on interrupted time series design. And what we chose was a composite care quality measure, which is made up of different clinical domains, quality indicators in different clinical domains. Val had mentioned earlier about the QIs. These are the same quality indicators that are on the nursing home report card. And this measure is this composite is a very broad representation of these different domains. So it's a very broad-based general measure of quality. If we look at the trends in this quality measure over time, the program started in 2007, and here we're comparing the trends in the two groups, those that were funded by the program and those that were not part of did not get PIPP funding. And you see the numbers of facilities there when we draw the comparisons. What you can see at the beginning there, the program, is a divergence. The PIPP-funded facilities increase their quality, and then they have maintained that significant difference over time. The bump here, that was the MDS version bump that you see going up there. We changed the states changed their version of the MDS, and it had an impact on the quality indicator measures and kind of bumped them up there. We're not seeing that continued increase, but it was a changeover in the measurement effect. But you can see here clear increases in the quality score. The other question is, when the facilities focused on a particular area, was there a detriment in other areas? And here we're looking at the facilities that had a clinical focus, and that was projects that did projects with clinical focus, and that was 105 facilities in this case. And we looked at a broad range of quality indicators in the clinical area, and we found significant increases in all 6 of these areas. So even though a project, for example, focused on falls, it also demonstrated increase in other areas as well. So there was, instead of diverting energy or diverting attention away from a particular area, it seemed to have a spillover effect, a positive spillover effect into multiple quality domains. The question of sustainability is an important one, and we've had enough experience now with the program and have enough projects have finished that we were able to do a survey this fall to ask facilities whether they had maintained their projects or not. And we found overwhelmingly that and this is 1 to 3 years after completion, at least 12 months after completion, that in half the cases, the projects were almost completely in place. They had found a way with their own internal resources to continue those. Another 37% had some minor changes, and then you had a few with some major changes. So we also ask about the various improvements, organizational, quality, satisfaction, et cetera, that had occurred during the project, and that the respondents said that those had been sustained as well. So there was a feeling here, or perception at least, on the part and the report from the facilities, that they were sustaining their efforts beyond the ending of the funding. Now let me, I'll briefly go through some results from our qualitative case studies. There were 2 arms of the evaluation. One was a quantitative arm, the other is a qualitative arm. What we did was we did case studies of selected projects. We inquired about organization and culture, barriers and opportunities, and so on. We had 13 projects, 70 facilities, and we visited those facilities, and we did a data collection on site, talked to a variety of different individuals. In total, there were 265 interviews. I'll just review here briefly some of the high-level findings from those interviews and those case studies. First of all, challenges. Well, this is no surprise to you, I'm sure. Even with the PIPP funding and with the PIPP support, there were challenges of finding the resources, adjusting to new routines. Any kind of change is difficult to deal with. Buy-in, establishing buy-in or dealing with resistance to change, the perception of more work, the turnover. Once you have a staff in place, when the people leave, you have to worry about how to reorient new staff. Selecting an outcome measure, as Valid mentioned, it's important to get a measure that you think you can have an impact on and set realistic goals, and then finally training. The top successes, and these are themes that emerged across all of the different interviews, all of the different case studies. Better relationships and teamwork. Doing projects together builds relationships and teamwork. Improve quality of care and quality of life. The perception, not only the quantitative measures, but the perception that we had improved quality of care, that we had hit our targets, met our goals. Greater efficiency. Better quality can lead to better efficiency. Increased staff knowledge and competence, being involved in a project, learning how to do root cause analysis. All of these builds staff knowledge and competence. Satisfaction. Staff are happier, residents are happier, families are happier. And then better quality improvement skills. And this is a very important area. We've written a couple papers on that. The use of evidence and the collection of data, root cause analysis, those kinds of quality improvement skills, opportunity, or first of all, the need with these projects to use those skills and develop those skills, and then secondly, recognition of how they improve quality performance. Advice to others, and we have actually a top 10 list. I've got several of those here, but we have a top 10 list from the study. Plan, plan, plan. Planning is very important in any undertaking. Doing root cause analysis, choosing outcome measures carefully on down the line. These are the sorts of, we ask a question in the interviews, what advice would you give to others who are doing these kinds of projects? And these are the areas of advice that emerged. And then PIPP value from the leadership perspective. We did interviews with executives in the facilities and also with the corporate leadership. And these are the sorts of themes that emerged from those interviews. The value returned to the facility and to the organization from the leadership's perspective were in a number of different areas. I'm going to give you a case example here of a project called Awakening. And Awakening was a project to reduce inappropriate antipsychotic medication. And these were mainly people with cognitive impairment and evidencing behavior problems or risk of behavior problems who were on antipsychotics but had no history of mental illness. And this is a big problem in the States, and I'm sure all over, is how do you deal with behavior? And drugs have been the first order of choice. So this nursing home chain, which is a nonprofit chain, Ecumen Corporation, decided to take on a PIPP project to improve prescribing and to implement non-pharmacological interventions. And the project lasted from 2010 through 2012. As far as antipsychotics are concerned, inappropriate use of antipsychotics, there was a definite downward trend. You can see the situation for facilities as a whole, pretty much a flat line there, and then what happened in the Awakening case. And they definitely reduced the rate of antipsychotics. They went from about 14% down to around 8%. So there was a definite reduction in antipsychotics. I don't have a graph here, but if you look at their reported behavioral problems, one of the fears as antipsychotics go down, problem behaviors go up. In fact, problem behaviors went down significantly. So what happened, and this is, is oftentimes the use of the antipsychotics can exacerbate behavioral problems, or they're a quick substitute or a quick fix, or perceived quick fix, but when you do the behavioral interventions, that's what really makes a difference. The impact reduction of antipsychotics was across the facilities. So it wasn't just a couple facilities or a few facilities, it was a broad-based impact. So what was the value, and this is through interviews with the the leadership of the ecumen and the staff of the projects and the facilities. Better addressing behavioral problems, improved interaction among team members. Campuses are noisier and more alive. Residents perceive more appropriate care and diagnoses. Family members also very positive. And people getting to go home. Organizational impact creates a culture of quality and excellence, develop a robust quality improvement process, increase collaboration across the ecumen facilities, and finally, empowering staff to innovate. And these are themes that emerged from the interviews, and they were pretty consistently reported. So, in summary, what we have found in the evaluation is that PIPP has promoted provider-initiated quality improvement. We see it as complementing other quality improvement initiatives, and there's research evidence for an impact in all those different areas. So, questions? Oh. Yes.
Hi, good morning. Based on the examples that you've given with PIPP, I'm just wondering, how do you share, you've got many, I'm sure, success stories. Are you able to share those with other nursing homes in the States? Or, like, how does that work in terms of other homes picking up on the successes of other long-term care homes that have been part of the PIPP project?
We do put some efforts into trying to disseminate those, and like I mentioned, our providers do a great job. Just like you, the trade associations have annual conferences, and you'll see lots of PIPP projects being presented by the nursing home staff at those places. But probably one of the most successful things is that we start to see, particularly some of these larger collaboratives that do some of this really innovative work, individual or freestanding individual facilities actually apply to PIPP and duplicate those programs in their facilities. And like I said, in some cases along with a mentor, but not always, because no matter what the strategy is or the project, it has to be individualized to that organization. So that's probably the biggest impact that we see. And I also know that some of the really innovative stuff that's coming out from some of these organizations, they do a lot of national dissemination to other states themselves, and then as well as we do, as well as from the research perspective too. There are a number of other projects that are working on antipsychotics, and so have I looked at specifically? I mean, I know the individual projects are making success, but and some of the follow-along projects with other organizations are going beyond the antipsychotics and looking at med reductions in general, which is also a good objective.
So, just make a point too that this particular antipsychotics is one example of a measure that's on the report card, and providers can track those measures. And one of the functions of one of the positive aspects of the program is that providers go to the report card and they look at where they stand, and they pick, for example, antipsychotics. They not only had not only the staff was telling the ecumen leadership that this was a problem, but the ecumen leadership could go to that report card and see my facility compared to other facilities in the state, or our set of facilities are not doing so well. So it's the ability to have these statewide, in this case, quality measures, quality indicators at a relatively in-depth level. Falls, antipsychotics, pain management, et cetera, that you can pick out where you are in relation to others. And there's a tendency among the projects to the facilities to pick projects where they're not doing so well and where they can show improvement. There are areas of care. So, yes.
Hi there. You were talking about how it took us to move from sort of the strictly regulated program to the PIP, that it took a certain level of accountability, transparency, and creativity, and maybe a leap of faith on the part of the government and the operators. I was wondering if you can talk a little bit more about how that happened, anything specific.
Well, one thing I think that helps is in Minnesota, the regulatory agency and the payment agency are separate agencies. And so we are not, so we're Department of Human Services, Department of Health is a separate agency altogether that is responsible for the regulatory approach. And so I think that that in itself is helpful because we can look, our agency then is more of a technical assistant, type of provider or, a role instead of necessarily focusing on the regulatory. But so, interestingly enough, some of our projects have led to a different approach in the regulatory environment where, some of these things, I think, alarms, the reduction in alarms because they contribute to falls, some of the 2-hour check and change kind of thing. We've had providers that use actigraphy watches, and they've been able to convince the regulatory agency with data that people move enough at night on their own. It's not necessary for us to be doing that, and so we've had a lot of the providers have had an ability to impact the regulatory process through the PIPP program.
That was a very, very thought-provoking and insightful presentation. And the 3 C's, I kept thinking of that during your presentation: communication, change, and culture. And what you've done to ultimately get to where you are now is very commendable. Quality of life for our residents is what we're all here for, and you guys have done a lot of work. We can learn from you, definitely. On behalf of Ontario Long-Term Care Association, I would like to thank our speakers, Dr. Greg Arling and Valerie Cook, and please accept this as a token of our appreciation. Big round of applause.